Yeah. Navneet, please
Yeah.
make it
Dr.
live.
Malik, good evening. Dr. Malik, good evening.
Good evening, Arun. Good to see you.
Ready. You can start any moment, sir.
Okay, Arun.
Okay, sir. Good evening, everyone. Warm welcome to everybody. This is the first Ryzen class in this calendar year after the annual conference, which was held in a virtual and a hybrid way. Okay, so as a protocol, it is my pleasant duty to invite the President, Urology Society of India, Dr. Mallikarjun, for presidential address.
Oh, thank you, Dr. Arun. It's a great honor to be presiding over onto this, and it's a fantastic program which has proven its worth in the last few years. An excellent program what is being conducted thanks to Rajiv, the chairman of ISU, and you who have been conceptualizing this very well. Well, that is the first thing in our tenure, possibly after our conference is over. And it's a smart learning program for the USI residents, and hope everything goes on well in the near future for the next 1 year also. We have fantastic topics. Chandra had been very instrumental in talking on hypospadias at a short notice. Thank you, Chandra Singh, for doing that. Thank you, Arun, and all the best for this program.
Thank you, sir. Thank you very much. Now, I have a privilege of inviting Honorary Secretary, Urology Society of India, Dr. Keshavamurthy, for his address. Dr. Keshavamurthy, over to you.
Thank you, Dr. Arun. Mr. President, Chairman of the ISU, Dr. Rajiv Sood, Co-Chair, Dr. Arun Chawla, and I think Pavan Raj Chalis from Nepal also has joined. He's the Secretary of the SAARC region. He was kind enough to, at a short notice, accept to send this information to the SAARC region also. So henceforth, the SAARC region residents also will be joining us in this Smart Residence program. I urge all the residents to disseminate this information, and it's going to be good faculty who will be taking classes to you. You should understand that the faculty will put in a lot of effort for a lecture like this. So make use of this and attend the programs regularly. It's not going to be very frequently. I have planned it to be once in a fortnight, and it will be after your working hours. So make use of it. I hope you will all enjoy the session today by Dr. Chandra Singh.
Thank you, sir. Thank you very much. Now it's my privilege to invite Chairman, Indian School of Urology, USI, Dr. Rajiv Sood, for a few words. Over to you, sir.
Thank you, Dr. Arun. And I welcome and again greet on behalf of Indian School of Urology, Urological Society of India, our President of Urological Society of India, Dr. C. Mallikarjun, and also our Honorary Secretary, Dr. Keshavamurthy. This is a great moment that our this year's programs, we are starting with this lecture only, and we are privileged to have Professor Chandra Singh. And in this, the two specialties, you can say reconstructive surgery and pediatric surgery, pediatric urology, both are concerned with this lecture, and as our country delegates are also, and faculty is also today with us. And with this, the President USI, Secretary of USI, and with the co-chair, Dr. Arun Chawla, I think we all are now inaugurating Dr. C. Mallikarjun, our president. So you declared this New Year's programs open, inaugurated today with this great program, and we welcome all Professor Chandra for this great lecture. Dr. Mallikarjun, please declare
Yes,
this. Okay.
Thank you, Rajiv. I think it's inaugurated already, and we are all going to have a great lecture by Chandra Singh. Well prepared for that.
And with the great news that in the Euromed program also on 13-14, today I received the message that robotic module, the robot is included. We are able to include in this program also. And we will have many great programs in Indian School of Urology this year. Thank you, everybody. And now it is all handed over to Dr. Chandra Singh. Dr. Chandra Singh, please.
Thank you, Dr. Rajiv. I think we are all set for Dr. Chandra Singh class. I think everybody knows Dr. Chandra, but still for the regents, Dr. Chandra Singh is professor at Department of Urology at CMC Vellore. He has finished his 2-year fellowship at the USA in the field of pediatric urology. He's actually actively involved in the clinical and the basic research in the field of pediatric urology. And last year, he was instrumental in organizing many pediatric urology events under the aegis of the USI. The pediatric urology webinars, the pediatric urology quiz competition, the interzonal and the international festival. He has played a major role in making this program very successful. I think he's touching a very, very important topic. As a residents, as you know, if somebody is doing hypospadias surgery, residents will try to go to the other OT because they feel they will not be doing it. It is very important to understand that most of the hypospadias nowadays is being done by the pediatric surgeon and even the plastic surgeon, and urology slowly and slowly they are losing it. It's very important we listen to him very carefully and try to inculcate the subject as well as the knowledge involved in the reconstructive urology skills, so that we take on ourselves how to keep this field of hypospadias reconstruction to ourselves. Especially as a resident, it's very easy to understand that the distal penile hypospadias, which is the majority of the cases, 70-75% is the distal penile hypospadias, is easy unless and until you clearly understand the principles and the basics. I think these will be made amply clear by Dr. Chandra Singh in his talk, who is covering this subject today. And I welcome everyone. And over to you, Dr. Chandra Singh.
Thank you. Respected Professor Rajiv Sood, our chairman of the Indian School of Urology, and co-chair Dr. Arun Chavla, and our president Dr. C. Malikarjun, and secretary Dr. Keshav Murthy. I thank you very much for this opportunity. I consider it a great privilege to be the opening batsman for the starting program. And I'm so delighted that we are able to involve in this teaching program, so that whatever bits and pieces we know, we'll be able to share among residents from all over the country in setting new standards of learning. May I share my slides, please?
Yes.
Is my slide visible, please?
Yes, Chandra, you're visible and you're heard.
Thank you. So I'll continue. I'd like to specially thank my colleagues, Dr. Sudhindra and Dr. Selvin Jain, who work with me in the field of pediatric urology. They are my budding colleagues who have expressed enormous interest, and they have prepared a significant bit of my presentation along with me. So as Dr. Arun rightly mentioned, we do encounter a good number of these distal hypospadias. And some of the points that we learn and we incorporate in our learning will enable us to give good care to these patients who we may be coming across once in a while. And I fondly remember the conversation I've had with some of our trainees who have gone to be consultants in remote parts of the country. And they realized that, as Dr. Arun mentioned, that you may run away from one OT to the other when it comes to hypospadias. When you're stuck in a situation, when you're in a remote corner of the country where you have several of the children coming to you and they don't want to go anywhere else because they are so delighted with your care, it is good to have some of these tricks up your sleeve so that you'll be able to care for these children. So we have a very wide spectrum of these children. For example, you see this first one where you have a very nice glans cleft and a very wide plate. But paradoxically, the next one, you have a very narrow plate, but hardly any chordae. And in this particular one, you see that there is a fairly proximal meatus. This child also had a meatal stenosis and a severe chordae. And the next one is a very severe chordae with a very short plate. And, it's almost sure that you will have to do a stage repair. And in this particular child, the plate is wide, but you see that the urethra is quite hypoplastic. So you have a varied spectrum of these children who we encounter. So by the end of this presentation, my desire is that you will be able to differentiate these types of presentation and the kind of manifestation, and you will be able to decide on the plans and to be able to meaningfully have an interaction, make a treatment plan. So the outline of my presentation will have some bit on the epidemiology, the embryological basis, classification, timing of repair, general principles and evaluation, and the role of preoperative hormonal stimulation, principles of surgery, and we'll have about 10 to 15 minutes towards the end to discuss all those questions. So kindly put your questions in the chat box. So if you look at the epidemiology, we do have a fair number of children presenting with hypospadias, and it's about 1 in 350 or 3 in 1,000 live births of children who present with hypospadias. And the etiology is probably multifactorial. There is some endocrine disruption and some hormonal factors, and possibly genetic basis also, where brothers have a higher chance of having hypospadias. And we know that several syndromic associations are there. And in terms of androgen insensitivity, partial or complete androgen insensitivity can manifest varying degrees of severity. And if you look at the embryology, there is a classic triad where you have a dorsally hooded prepuce and proximally placed urethral meatus and a ventral penile curvature, as you see in different stages in the development of a male. And what is the reason for this? The reason is that there is a failure of a midline perineal mesenchyme to grow ventrally. This is normally supposed to cover and complete the urethral plate to form a tube. And when there is a deficiency, this causes an ectopic orifice. And in terms of the dorsal skin, there is failure of androgen-dependent growth of ventral mesenchyme. And as a result, there is this defect that happens ventrally. And that results in the formation of a dorsal hood, which causes an overgrowth. And these children are associated with a CORDY, and the severity of this CORDY is related to how deformed the penis is. And there is an arrest of the mesenchymal growth and the deficiency of the periurethral growth, and possibly associated with the bend of the corpora, and that causes a CORDY. And it's important to have an idea of the blood supply of the penis. And I'm not going to concentrate on the blood supply of the phallus, but on the skin. And we know that there is a superficial superficial external pudendal artery, and that causes formation of the superior and inferior external pudendal artery, gives the two branches, dorsolateral and ventrolateral branch. And as these two occur on either side, this forms the basis of the blood supply to the penile skin. And as you observe, this is paramedian, and these vessels are going from proximally to distally in a paramedian fashion. That is the basis of any midline incision on the skin, not inadvertently affecting the vascularity of the flap. So this is not a midline vessel and two paramedian vessels on either side. And that is what causes the flap, something like a bias flap, to be raised without causing any devascularization. And in terms of this section, if we carefully observe, there is rich anastomosis between the dorsal penile artery branches and also the superficial arterial plexus. These fine capillaries and vessels form an anastomosis. So when we raise this flap, there will be invariably division of these vessels that connect with the dorsal penile branches. But nevertheless, if we preserve the vessels that come on the skin flap, this retains this rich vascularity without having any compromise because of the division of this capillary plexus. That is also important in terms of raising this flap, degloving the penis, which I'll be covering shortly when I come to the surgical techniques. Now, how do we classify this hypospadias? Right from 1938, we've had classification methods based on varying degrees of severity, first degree, second degree, and third degree. And it's all related to the location of the meatus, whether it's glandular, subcoronal, midshaft, penoscrotal, or perineal. And the one which is more commonly used is ducats, which classifies as glandular and then subcoronal, and the distal penile and midshaft are classified as anterior and middle. And the most severe ones are the proximal penile or penoscrotal. And this is the classification which is based on the severity. Now, why this is important? Because the degree of severity determines the extent of CORDI, and that will also determine what kind of operative choice that we are going to take. And in terms of documentation, it is important that we enlist all these features. And this is enumerated in Dr. Hadidi's textbook of hypospadias. And what all do we document? Where is the urethral meatus? And as you are aware, probably, that the urethral meatus location changes after the degloving of the penis. Initially, it may appear to be falsely quite distal, but after the penis is degloved, the meatus moves proximally. So we need to document how it is before the CORDI correction and where the meatus is after the CORDI correction, and whether the prepuce is complete or incomplete. How is the glans and the glans cleft? Whether it's a complete cleft, incomplete cleft, or flat. You may recollect the first image that I showed, where there is a very flat glans, which is inadequate for tubularization. But on the other hand, as you saw in the very first picture where the cleft is very deep, you know that the options are many more in terms of being able to tubularize this. And how is the CORDI? Whether it's a superficial CORDI or whether it's a deep CORDI, whether you can feel the skin alone tethering the penis down, or whether you feel there is some kind of a corporal disproportion also. And how is the width of the urethral plate? If the width is less, we know that less than 1 centimeter, we know that tubularization has a higher chance of failure. But if the width is more than 1 centimeter, we know that we can get a comfortable tension-free tubularization. Then is there any associated torsion? Because we know that if there is torsion, then the extent of deformity is even more severe. And also we look at the scrotal transposition. If there is scrotal transposition, which is again highly indicative of hypovirilization, we know that it can be an extremely challenging reconstruction and which will require a more staged repair. And how do we objectively score? And there is a score called a Hope score, where we look at the hypospadias objective penile evaluation score. We look at the location of the meatus, shape of the meatus, and shape of the skin, and presence of torsion and curvature and penile erection. And based on all this, you assign some points so that we can compare apples with apples in terms of comparing results of reconstruction. And here we see that with the extent of increasing severity of the CORDI, the score tends to be higher when we know that the reconstruction is likely to be more challenging. There's another slightly different variation, which is a HOSE, hypospadias objective scoring evaluation, where again, based on this extent of severity, the scores can be more if the hypospadias is more severe. The next question that comes is, when do we repair this hypospadias? And here we need to have a good balance between the emotional and sexual development of this child, psychological effects of surgery and anesthesia. And earlier it was perceived that anesthesia in infants is not very safe. So more than 1 year or more than 2 years was a common assumption. But now we know that even 6 to 12 months, very safe anesthesia and reconstruction can be planned. And in addition to the psychological impact of doing it early, it is also beneficial in terms of healing. We know that the infant's penile healing is much better than the reconstructions than in older children. So that is how we, the optimal window we say is 3 to 15 months, and we can comfortably say if we narrow it down, 6 to 12 months is a optimal time for a reconstruction if we have the anesthetic support. And in terms of family history, we need to find out if there are any siblings who have hypospadias, and if there was any maternal ingestion of hormone treatment during pregnancy, threatened abortions, maybe a high dose of progesterone, and an examination, we do all this assessment and then document all this. And what is the role of imaging? Probably not in distal hypospadias and penoscrotal and perineal hypospadias. Ultrasound abdomen is mainly to document any associated urinary tract anomalies. And in a perineal hypospadias, there can be an enlarged utricle, which may pose challenges in reconstruction, which we'll mention about later. And they may be associated anomalies like an undescended testis or a hernia. And karyotyping, there are those who advocate karyotyping even in distal hypospadias. But in terms of its role in management, probably in those with other features highly suggestive of DSD, where there is a undescended testis or a very unequal scrotal development, very hypovirilized scrotal appearance, and if there is a one-sided hernia, which is suggestive of some an organ prolapse and all that, then you may do a karyotyping. And if there is a strong suspicion of DSD, we may need to do, in addition to karyotyping, we'll have to do electrolytes, plasma 17-hydroxyprogesterone, and testosterone measurement baseline. And after, HCG stimulation has a role in some of these children to see if it's related to end-organ insensitivity. And what is the normal stretched penile length in a newborn? Usually it is about 3.9 centimeters, which is ranges usually from 3.1 to 4.7. And if it's less than this, we know that there is something strongly suggestive of testicular response to the testosterone. And we may need to look at androgen stimulation, which may be either as a HCG or testosterone stimulation. And testosterone may be used as either as a topical application or as an injection intramuscular. And there is also documented benefit of a HCG injection as 2 or 3 or even up to 5 weekly courses. But this is a transient response, which we need to note. That is not like a permanent response, but at the time of operation, possibly there is increase in penile length and reduction of chordae. And several studies have documented that. And we know that the overall complication rates are lower, and possibly the urethocutaneous fistula rates are lower in these children. And there is a systematic review also, which documents a good response in most of these children, especially when the phallic length is shorter than 4 centimeters. In those who have a good gland size, good width of the tube, adequately virilized penis, possibly it is not beneficial. Then I need to focus on some of the principles of surgery. As you are aware, this is a reconstructive surgery. So we need to ensure that we have meticulous attention to detail. We should position them appropriately. And in those who have a penile hypospadias, where there is no need for anything in the perineum, it is better to do in a supine position, because standing by the side of the child gives a better optimal ergonomic operating. But on the other hand, if there is a penoscrotal hypospadias and perineal hypospadias, we may need to have the infant position, a lithotomy position, so that we can access the perineal urethra. And it's good to use loop magnification, and we need to have adequate traction. And one of the things that I commonly insist is that we need to have the drapes properly positioned, so that this traction stitch can be clipped to the drape. Because one of the most inefficient way of operating is to have the first assistant holding this traction. So in that case, the first assistant's hands are locked up, and they are not in a position to hold the skin flaps to assist us. But on the other hand, if we have the gland stitch that is clipped to the drape, I'll be showing in one of the pictures later, then we know that the first assistant's hand can be free. And we don't want too thick a suture to go through the glands. We don't want anything bigger than 3O. 3O is for older children, but 4O is better. And in addition to that, it's better to use stay sutures or skin hooks to minimize damage to the skin flaps. And it's good to use fine tooth instruments for the skin, and the tissue hydration should be ensured. And it's good to use delicate fine cautery. I'll be showing you a needle tip cautery in one of the pictures. It's good to have that if possible. And this is the Westgard scissors. It is used by the ophthalmologists also for incisions on the iris and all. What is the advantage of this? It's ergonomically better. You don't need to be having your arms fully pronated as with the usual medicine bomb scissors. So if you have it, it's a luxury, especially when you deglove the penis. But if you don't have it, it's fine. And also we need to have fine tooth forceps. And in terms of needle drivers, it's good to have fine needle drivers, which can hold 6O and 7O needles. We don't have fine needle drivers. The needle tends to rotate because the jaws don't hold those needles well. And also, if you're using fine needles with a very large needle drivers, you're taking the needle out of the tissue using those large needle drivers, they tend to damage the tip of the needle. And then the next bites can be blunt, and then that can traumatize the tissue. What are the goals of the repair? We should straighten the penile curvature, which is of paramount importance. When I come to one of the secondary complication picture, I'll be highlighting this again. So in the first stage, we should ensure that the chordae is corrected completely. Because if you get a good urethral reconstruction, but if the chordae is not corrected adequately, it is a recipe for disaster, because you will have to intervene again later when the child or adolescent or adult comes to you with persistent chordae with difficulty in having intercourse. The next one is advancing the urethral meatus to a normal or near normal location. And this is one area where sometimes we have a struggle. Do we aim for a perfect anatomical location at the tip of glans, or is it okay to have it somewhere in the distal glans? Especially in children whose glands have not developed well, I have seen quite often that with enthusiastic attempt to approximate the glands together, it is possible to bring the glans tissue together with a stitch, but that causes a lot of resistance at the glans, which results in a proximal fistula or having to calibrate this child again and again. So sometimes it may be realistic to compromise on the location of the glans of the meatus at the glans tip than to have a lifelong problem for the child in terms of self-calibration. And we should also desire to enable the child to void in standing position and to be able to have normal ejaculation. And as I mentioned, 6 to 9 months is a good time. And I've often found that keeping a dripping splint draining into the diaper easy to manage. If we have it draining into a catheter and the catheter is anchored to the abdominal wall, it is much more difficult for the mother to carry the baby around. But as these babies are not toilet trained, to have a splint that is draining to the diaper, it can be a double diaper where you make a hole, button hole in the inner diaper so that the splint comes out to the outer diaper. Then it's very easy for the mother to handle, and the children are less irritable, and you can let them carry the babies around. And this is how these repairs can be done even as a daycare, because in the United States and in UK, all these are done as daycare. You bring the baby in the morning, do the hypospadias repair, and then by evening the babies are feeding well and they can go home. Hopefully in our country, we'll be able to progress to that level soon, especially if we have short-acting narcotics like remifentanil and other medications, which still are not very widely available. Once that is there, we should also be able to do that. But if we have long catheters draining into urosacs, all that can make the procedure messy. And also, we should ensure that the tissue is supple and there is limited memory for the sutures that we are using. Antibiotics, usually 1 dose of prophylactic antimicrobial and possibly continuing some oral cotrimoxazole till splint removal may be an acceptable option. And intraoperatively, it is good to have a caudal penile block, especially if you're planning to discharge the baby, and they're less irritable with a good post-op analgesia. Unfortunately, we don't have oral codeine. The paracetamol codeine is a good oral combination, but in our country, it is not licensed. As a result, we are not able to have good post-op analgesia with oral analgesics. And then infiltration is variable. Some prefer 1 in 100,000 adrenaline with lignocaine for local infiltration, but you can do without a local infiltration also. And it's good to have a vessel loop, a feeding tube, tourniquet, 20 gauge butterfly needle, and some saline for infiltration. What are the sutures used? As I mentioned before, for gland extraction, we use a 4-O-proline. The large glands, older people, we may be using a 3-O-proline. And for the tube reconstruction, commonly we use 6-O or 7-O PDS. And PDS, one challenge is sometimes if you're stretching the thread, it retains the memory and it can make the further continuous suturing more challenging. And for the skin, we use 5-0 Vicryl Rapid because you don't want to have a non-absorbable and have a difficulty of trying to remove the skin sutures for these babies. And urethral splint, we usually use a IFT, 6 to 8 French. We leave it for about 7 to 10 days. The distal ones can stay for 7 days. There are those who remove them earlier also. And especially if it's a subglandular or distal penile one, you can comfortably remove the splint earlier also. But 5 to 7 days is optimal. Just a simple tegaderm dressing and an offset over a gauze is sufficient. We don't need to do any elaborate tight dressings, especially if you are discharging the baby the next day, because you don't want to have glands hypoperfusion and ischemia. And what I have noticed in my short stint in the US in 2 years is that having this splint draining to the double diaper keeps the wound clean, unlike having an elaborate dressing with a lot of concretions around the tube stuck to the glands, keeping it unhealthy. And paradoxically, we think that the wound getting urine may be unhealthy, but interestingly, that remains clean compared to some of these dressings that I have done earlier. So nowadays, I try to use only this splint draining to a diaper. And oxybutynin in case of bladder spasms, occasionally required, and stool softness also. And we should ensure that we follow up at 6 weeks and at 1 year in toilet training and also at puberty. Because if you listen to the experience of those who have had a long-term follow-up, a good number of these whose short-term results are excellent tend to have suboptimal outcomes in the long term. So it is good to have a track of the long-term follow-up of these children. Now I'll go into the operations that we choose for these hypospadias. And Dr. Arun, do I stop for any questions or discussions now, or shall we keep it to the end?
No, we'll keep in the end only. Please continue.
Sure, thank you. Okay, I'll do that. So this is one slide where I'd like to spend some time. How do you determine what operation to perform? This is one of the questions that was passed on to me earlier. So it is important for us to decide which operation to perform based on the degree of CODI first. If it is a severe CODI, sometimes one of the pictures that I showed earlier, the meatus was distal, but the CODI is fairly severe. So you, as I mentioned once before, I may be repeating it again, you should ensure that you are releasing the CODI completely in first operation. So even if the meatus is distal, if the CODI is severe, then your options are limited. Then where is the location of the meatus, distal versus proximal? And again, if the tube, if the plate width is not adequate, then you may not want to do something like a tip. You may want to augment that. And again, if the glans groove is adequate and if the plate is deep enough, and how's the skin availability, whether the procedure is a primary or a redo. These will determine the operation that we do. And the procedure to straighten the CODI is also called orthoplasty, where you straighten. And this ventral curvature of the penis, in epispadias, as you are aware, the CODI is a dorsal CODI, and here it is a ventral CODI. And when we release the skin, which is tethering this, good number of these CODIs get corrected. I'll be showing a picture shortly. And we also will need to ensure that the dysgenetic dartos or Buck's fascia is trimmed and cleaned and excised. And if there's ventral cavernosal deficiency, we'll have to address that. We need to do this in a stepwise fashion. First is to deglove to see if the CODI is correction. If that is not satisfactory, we'll have to look at some kind of application. I'll be covering that shortly. That is not satisfactory, then we'll have to look at the division of the plate. And otherwise, if you feel the plate is adequate with mobilization, it will be fine. You may just mobilize the plate off the corporal bodies into ventral corporotomy. So how do you do? In this picture, if you observe, for example, this is splint that's in the urethra. And here you see that you can almost almost see the tube through the skin. So what that means is that though the meatus is distal, over here, there is so much of, I think somebody's mic is on. Yeah, thank you. It's so hypoplastic that the skin and the urethral mucosa are together, and the corpus spongiosum is so divergent. So this cross section gives an idea of where we deglove. And so here we need to be sure that we are superficial to the buccal fascia, and this areolar tissue gives us the plane where we need to deglove. And we have the skin and the superficial dartos fascia, which is mobilized off from the areolar tissue. So here we see that after this degloving, we know that this divergent spongiosum is enumerated. Here you see that the spongiosum is divergent, and that is obvious after the degloving of the penis. So here we see that after we deglove, we do an artificial erection test, and then we again determine how the caudy is. So here we can measure the degree of caudy and then determine what is the next step to be done. So here this is the foreskin hooded prepuce, which is lifted up, which will be used for the next step of repair, depending upon where the urethral meatus is. So once we have degloved and we have found that there is persistence of caudy, we may either go for a single dorsal midline plication, which is also called a Baskin's dorsal midline plication. Now, what is the logic? We in the microanatomical studies is noticed that the neurovascular bundle is paramedian and the midline is essentially free of the neurovascular bundle. So taking a dorsal midline plication will correct a mild caudy if it is in this infantile age group. It may be a 5O polypropylene, 1 or 2 in the midline, so depending upon where the maximum location is. And if we take the first bite inside out here and then go around and take outside in, the knot gets buried in. So that knot will not be felt through the skin. So that may be another useful tip when you are taking that. And if one is not adequate, you can take one more. And we need to keep in mind that any plication and dorsal shortening procedure results in shortening of the penis. So if the penis length is already less, you may wish to avoid this plication dorsally and go for a ventral procedure. And with recent publications, we know that there is a fair bit of recurrence of caudy when the children are followed up long term. So that is one thing we need to keep in mind. Next one is a Nesbitt excision and plication. So here what we do, we apply something like a baby Alice in the areas of where the caudy is, dorsolaterally. And then we do the erection test again. And then if we are satisfied with how the caudy correction is, then we excise a bit of the tunica, and then we take these stitches. So this results in a definite reduction in the tunica dorsally, and that results in correction of the caudy. So here you see this is a picture where the baby Alice is applied, and that helps us to look at how the correction is satisfactory or not. But when you need to do 2 or 3, you have to be very careful because that results in a marked reduction of the dorsal length of the penis. And as I mentioned earlier, if the length is short already and we do not wish to do anything dorsally, the next option is to do a ventral corporotomy. And we can either put a tunica vaginalis flap or a graft or a dermal graft. And this is usually done at the point of maximum curvature ventrally. This is more anatomical. But the challenge here is once the ventral division is done, it is difficult to check the adequacy of your correction because when you inject saline, it tends to leak from the ventral incision. But nevertheless, you are more likely to correct the caudy ventrally without doing any dorsal plication. So here again, when we see after all the releasing the caudy tissue, if there is persistent caudy, then we may have to go for the next steps of correction. So here, once you've tried, you see the penile length is also short and the butterfly needle is injecting the saline. there's persistent CODI, you tried all the dorsal and ventral steps, and then if it's not adequate, then the next step is we'll have to divide the urethral plate. So I mentioned about the needle tip diathermy. This is a very common, very useful adjunct for hypospadias surgery. Now, why this is helpful? Because the energy is more precise and it is less damaging to the lateral tissue, and it is good to have one or two of these steps. So this is the algorithm for CODI correction. We do the penile degloving, do the artificial erection, and we check if the curvature is resolved. And if it is resolved, we'll proceed with the urethroplasty. If there is persistent curvature, and if it's mild CODI, we can either do a dorsal shortening procedure, like a plication, midline, or a lateral. And then if that is satisfactorily corrected, we go for a urethroplasty. And if not, we can go for a copper lengthening procedure. Or if if the CODI persists, we go for a two-stage repair. Now, after discussing about the CODI correction, we talk about the urethroplasty. Here, as I mentioned earlier, we need to check if the glans width is adequate, more than 14 millimeters, or the urethral plate is more than 8 millimeters. Here, we get a better outcome. We'll have a tension-free, watertight closure of the urethra if we have a urethral plate like that. And usually, absorbable monofilament 6O or 7O PDS is used. And second layer may be of added benefit. And second layer is possible if the plate width is adequate. If even for the first layer, we need to kind of snugly close. Trying to close the second layer on top of it can cause further narrowing of the urethral lumen. And it's good to interpose either dartos or tunica vaginalis tissue to reduce the chance of fistula formation. I'll be covering this later. And myomeatus positioning is aimed at mid-glans if possible, and that is covered by the glans. That will enable having a slit-like meatus so that the child can pass urine without spraying of the urinary stream. So this is how we measure the width. If you are making a plate from the skin, you use a caliper to measure, or otherwise you do a distal hypospadias repair using one of the other simpler techniques. I'll now go for some of the named techniques. We have this magpie where you have the meatoplasty and granuloplasty incorporated, where we tend to correct the deformity in the glands by making a longitudinal incision and correcting it, suturing it transversely, which gives a granuloplasty. And then by raising the glans wings and putting the urethral tube there, we can bring the glans around and approximating here, results in correction of the distal glans hypospadias. The advantage of this is that the urethral tube is not disturbed at all, so the chance of fistula is near zero in this if the urethra is left intact. And this gives a cosmetically adequate, satisfactory repair with the urethral tip at the meatus. And the next one is another simple one called the gap procedure, which is glans approximation. Here again, this is suitable for glandular hypospadias. And this is usually encouraged if the families are very strongly particular to repair, and some of them with adequate counseling may say they are not too keen on repair. So here, this repair is with a mobilization of the flap within the glans itself and approximated so that the meatus is advanced to the tip. This Matthew repair, I'm just mentioning for historical reasons. It's not being commonly done, but there are a few who still sincerely believe. So here it's a parameatal flap, which is mobilized from a proximal urethra, where you can mobilize the flap and advance it right till the tip to cover the deficient tube. And then following that, you can bring the glans together to after suturing the parameatal flap distally, and then the glans is sutured on top to complete the repair. Matthew repair is not very common now with the advent of other more anatomical repairs. Tip is Thiersch Duplay repair, and then that is popularized with the dorsal incision by Snodgrass in 1994. This is commonly done for distal hypospadias, and preferably the urethral plate should be more than 7 millimeters. And CODI should have been corrected without urethral division, and only then we go for a tip repair. Where do we mobilize the plates? So here we should ensure that the glans cushions are retained. And we need to, as I mentioned earlier, the plate width has to be adequate. And then you make longitudinal incisions so that this give you adequate plate to be tubularized, tension-free. And then with this incision, the glands can be mobilized, which can be rotated around. Then note about spongioplasty. When a carefully performed anatomical procedure is done, we'll be able to easily make the incision on the cavernosa, the spongiosum to be mobilized off the cavernosa, and that tissue can be mobilized right into the glands to be able to mobilize the spongious copper spongiosum. Now, this is a matter of experience and ensuring that we are in the right plane. Often, when we are dissecting right into the spongiosum here, because often it's hypoplastic, we may say the spongiosum is not there. But when the dissection is started right proximally in the cavernous body, and we see the bluish cavernosa and get all the tissue from there to be dissected along the spongiosum, we can ensure that the spongiosum is dissected right into the glands. This ensures that you get a satisfactory spongiosum to cover the tube. In a good number of children, you'll be able to mobilize this. So that gives a second layer. What is the advantage? If you're confident of having raised a good satisfactory spongiosum here, you don't need to spend a lot of time dorsally to get a flap from dorsal dartos. And when you don't have to do that, this whole repair concentrates on the ventral aspect, and the proponents of a ventral repair focus on this and they have good results. But again, we should ensure that the chordae correction is adequate. And often we notice that complete satisfactory chordae correction requires a degloving of the penis. And if you are doubtful, then it's better to deglove the penis. Then I would focus now on the proximal hypospadias repair. So one stage for proximal hypospadias repair is again a challenge because we need to carefully weigh the risks and benefits of a single stage repair versus a stage repair and the risks of a persistent chordae or a breakdown of a single stage repair. So one of the common repairs that was very commonly done earlier was a transverse preputial island flap for a proximal hypospadias. But here again, you have a satisfactory chordae correction and you have a very narrow plate. Then you can take a transverse preputial only island flap, and that can be anchored ventrally, sutured ventrally to complete the ventral aspect of the urethral tube. And that gives a satisfactory single stage repair when you don't need to divide the plate. So this picture, I would like to highlight something that I had mentioned earlier. This is in terms of the traction and counter traction. So here, this scissors is that Westcott scissors. And you have traction that can be applied using fine mosquitoes. The skin flap has a traction, and these chromic sutures are on the flap. So that is giving traction on the skin on the other side. So you can do precise dissection adjacent to the dorsal skin so that all the vascularity is retained along with the flap. You'll also observe that the gland stitch is anchored onto the drapes. This is what I mentioned earlier about how you drape. So it is good to ensure that you have drapes that are not mobile, and you can anchor the traction stitch on the drapes so that the glands need not be, this glands traction can be retained to the drape and your assistant's hands can be free. So this is again another view. See, you see that the glands traction is retained on the drape and the penis is taut, and the surgeon's left hand is holding the dorsal skin and the right hand is operating on the Westgard scissors. The first assistant is giving counter traction on the flap with fine forceps. This enables us to raise the flap, retaining the vascularity on the penile skin. So this is again another transverse preputial island flap. And this is useful for an onlay island flap. This is a good one when you have a chordae correction, satisfactory chordae correction, but the width of the plate is narrow. you do an onlay island flap. So this is how the onlay flap is mobilized, and this is the dorsal plate. Some may argue that with this kind of a width, you may make an incision and tubularize it, but that's a matter of personal choice. Because if you're not happy that that width may shrink, if it is less than 8 millimeters, you bring a flap. Otherwise, you may make an incision and tubularize that. Then we go to a scenario where you will have to divide the plate. As I mentioned before, after your skin degloving, you find that the chordae is persistent. You have done a dorsal plication, you find that the chordae is persistent. Or you decided beforehand that even with the dorsal plication, the chordae will not be released. Or you feel that the penis length is very small, so you don't want dorsal plication, then you're forced to divide the plate. Then you have to decide whether you wish to do a single stage repair or a staged repair. So if you're doing a single stage repair, which was very common earlier, which is not that very commonly now, still the experts will swear by this. You may do a preputial tube repair, which may be one of these tube which you decide on the width of the tube based on how you wish to have the tube, which is about 15 millimeters, and the length you measure, and then you can make a transverse preputial tube, and that is brought ventrally, and then do a single stage repair. Now, what are the challenges? When you bring a tube like this, if you notice, this distal most has a most precarious blood supply that has to go all the way from there. And in order to bring that blood supply, if you continue to dissect between the dorsal skin and the flap, that can result in ischemia of the tip. But if you don't mobilize adequately, this will result in torsion. So you are caught between the devil and the deep sea. If you don't mobilize, you will have more of torsion. If you mobilize a lot, there'll be more of ischemia, stenosis, necrosis, and breakdown. That is the challenge with this preputial tube. But those, again, as I mentioned before, those are experts who have done large numbers, especially centers of excellence. They will swear by it, telling they are able to do with single stage tube repairs. Then you have to have some idea about the parameatal foreskin flaps. This is also called the Koyanagi repair. So here what happens is that you have divided the plate. So you need to get a skin flap, which is a parameatal flap. So this flap goes around from the parameatal area onto the dorsal degloved skin, and that is brought and then tubularized and a single stage repair is done. This again is less popular nowadays because the incidence of diverticulae and tube breakdown are quite high. But there are a few who have published series with impressive results. The advantage is that you get a single stage result. It was initially described by Koyanagi and then popularized by Nomura. So even in very proximal penoscrotal hypospadias, they were able to use one of these reconstructions. Then there are those who Perovic et al. Have talked about very radical reconstructions, like a penile disassembly technique. This is like the epispadias repair, where there is disassembly in order to get the epispadias correction. They disconnect the cavernous bodies from the glands. But the common experience is that the complication rates are quite high. And I'm just mentioning this for completion's sake. And there are several other repairs for distal hypospadias repair, Barcat, Larcat, and a whole lot of name repairs. More than 400 are there. And for want of time, I wouldn't go into elaborate details of those. And it is good to be aware of some of those names. However, it is good to be confident of 1, 2, or 3 techniques so that we can offer them well. If I were to choose 3, I would say tip for those who have a good wide plate and the chordae correction can be done satisfactorily. Second repair will be a ventral onlay for those where you can get a chordae correction but the plate is narrow. Third will be a stage repair. I would say for somebody who's not going to be doing frequently but who would like to do, I would say being comfortable doing these 3 procedures would be good enough to offer your services to these children. Now, when you're doing a stage repair, one of the commonly used flaps is a bias flap. You may recollect me mentioning about the blood supply. So you have two paramedian vessels. So the midline is avascular. So when you make an incision in the midline of this dorsal hooded skin, this enables you to bring it ventrally and then cover between the meatus all the way right to the glands, so that this flap gives a adequate plate with supple tissue along the side of the plates that enables you to do the second stage repair comfortably after 6 months. Then we also talk about Bracas repair, where you do a split thickness skin graft of this hooded prepuce. You anchor it, and then after that, in a second stage, which is done after 6 months or 1 year, then you can comfortably tubularize this. And plastic surgeons are quite comfortable, and they swear by the stage procedure. It is a stage 1, but it has excellent cosmetic results, and also there is no torsion. When we try to do a single stage, as I mentioned before, the chance of torsion of the torque is quite high. Here, there is no chance of torsion because you are not bringing a flap around. And when you have done a tubularization, it is good to try and bring the glands around the tube so that the meatus will be towards the tip of the penis. But here again, it depends upon the width of the glands, and it is better not to be over enthusiastic trying to take it to the tip and resulting in a full breakdown of this. So if I have to go for this algorithm, we try to preserve the urethral plate, skin and dartus dissection. This distal, you look at the glands configuration, meatus quality and location, assess the curvature, choose one of these distal procedures. But if dorsal plication is necessary and then tubularization is not grass, if not, go for an onlay or a 2-stage repair. I'd like to add a few slides on hypospadias cripple. This is a term which you will be hearing in those who have had multiple repairs and then failed. So here you see the tube is passed through the repair, and we have so many of the skin bridges that are in between holding. And we know that with the increase in number of increase in the complexity of the surgery, the complication rates tend to be higher. So the distal ones have lesser complications. The proximal ones have easily 15 to 30% or even up to 40% complications. And now what happens, this decision making is a tricky one, as I mentioned before. And the other challenges are that the objective evidence for success is very varying. As you know of many other operations, the surgeon may say it's an excellent repair, but patient may not feel so. The patient may not be too concerned, but a third person looking at it may find it horrible. So these are the various challenges which make it difficult to compare among various operations. And low volume centers and doing it once in a while can result in higher rate of failures. So proximal ones tend to have a higher failure rates. Misdiagnosis of those who have a DSD tend to have a higher failure rate. Not identifying an associated BXO can result in failure rate. And in the technique, the tissue dissection, if it's traumatic, with this extensive tissue handling, that can lead to higher failure rate. You may remember the step that I showed with traction, counter traction, and the raising the flap. There, if instead of following the curvature of the penis, if we dissect right into the flap, that can cause division of the vessels. So that can result in bleeding from the flap. And then when we coagulate that results in ischemia of the flap. And when we mobilize a lot and necrosis results due to overzealous cautery usage. And when we mobilize proximally, quite radically, there can be poor vascularity. As I mentioned about the single stage tube repair for proximal hypospadias, the distal tube can have a high chance of ischemia. And then if there's a hematoma under the flap, that can also lead to failure. And if we have not gauged the width of the tube, then we can suture it under tension. That again leads to a breakdown. and we try to get a two layers of closure, and that can make the suture be more tense. And also, if we are not anchoring the graft adequately in a stage repair, that can also lead to failure. Infection can lead to, again, failure and breakdown, inflammation. Again, as I mentioned before, when you are having the splint dripping into the diaper, the collection there and sweat and other dirt tends to collect lesser. And I would like to ensure that some of these points are highlighted, that the timing of our operation is adequately planned, 6 months to 1 year or 6 months to 2 years. And then those are very small glands to either use injection dihydrotestosterone or local application, and to ensure that the tissue flap that is available is adequately vascularized. And the complications can be graded as minor, just cosmetic grade 2 or grade 3, which is a major, where major functional complications are there. There are fistulae, persistent chordae, or meatal stenosis. And when you're assessing this patient, we need to assess how the tissue is. Where is the skin tissue? Whether how are the scars? Are they constricting scars? How lax is the penile skin? How early was the earlier repairs? Because when we find children who are operated 6 or 7 years earlier, their skin tends to be much more supple than somebody who was operated just 6 months ago. And do we have any preputial skin at all? Where's the urethral meatus? And is the meatus calibrus adequate, or if it is stenos? Is there still persistent curvature? How is the fistula? Is there single fistula or multiple fistulae? Is the skin between the fistulae having any subcutaneous tissue, or it's just a bridge of a skin holding together like the picture that I had shown? Is the fistula very proximal at the penoscrotal area, where there is a lot of tissue around to be able to repair there itself, or it is right near the glands and hardly any tissue in between? And is the fistula associated with a very narrow plate adjacent to it, or is the fistula with a long tract connecting to the urethra where we can comfortably divide and repair it together? All these will decide how we are going to do a fistula repair, and how irregular the urethra is also will be one parameter that will help us to decide. So these are the problems that you encounter: urethrocuteneous fistula and urethral diverticulum. A diverticulum is more common when you have a meatus which is tight and urethra that is lax, commonly due to some repair like a Koyanagi repair or a single stage urethral tube, have a higher chance of forming a urethral diverticulum, especially if the glands is approximated together. Recurrent stricture, which is because you have a narrow plate to start with and you have sutured it up together, can cause an extensive stricture. And Snodgrass had published that extensive mobilization of the urethra away from the cavernous bodies can result in recurrent stricture. There can be persistent chordae, meatal regression, stenosis, and this persistent chordae may result in compromised sexual function. And apart from glands dehiscence, the second most common problem is the urethrocuteneous fistulae, which is up to 20% in redo repairs. Some of them may be early, and some fistulae may occur much later, especially if you're doing in an infant. When they're in the diaper, the fistula may not be noticed till they become toilet trained. After that, the parents may bring telling there's some leakage of urine. Some of them may be large, and some of them may be multiple. But as I mentioned before, the location and how the tissue is adjacent to that enable you to decide how challenging the fistula is going to be. Unlike the size of the fistula, because sometimes it may be a large fistula, with a long tract, and you can comfortably close it. The success rates are quite high. And the free grafts have a probably higher failure rates with pedicle grafts. Earlier, they used to do a tube with a free graft, and that has been given up now because the failure rates are notoriously high. And if the suture lines are opposing, the failure rates are high. And for that, we need to attempt putting some interposing tissue. I'll be talking about that shortly. And if there is distal obstruction, failure rates are high. and vascularity and infection in previous fistula cause further failure rates. Here, if you see, for example, this is a proximal fistula, large fistula, but you can mobilize a lot of tissue around and success rates are quite good. On the other hand, this is a distal fistula, but the tissue in between does not give you any place to have anything interposing. The failure rates are quite high, and with hardly any tissue around that, the repair can be challenging. So, as I mentioned before, we should rule out any distal obstruction. Tight glands closure is a commonest cause of distal fistula. Suture material should be appropriately chosen, but it's not a very consistent finding. Some say that PDS, because a longer lasting, has a higher incidence of fistula, but it is one of the good suture materials because it's a monofilament you get in 6O and 7O size. And this interposing tissue I'll be coming to shortly. And some talk about fibrin glue gel for a short, small fistulae, but it is doubtful in its benefit. And it's good to delay at least 6 months. And surgeon may be in a haste trying to give a good relief to the parents' anxiety, but better not to repair earlier than 6 months. I tend to do even a second stage only after 1 year, because most of the patients come from far off. For them, coming after 6 months and coming after 1 year is no different. And I prefer to do it after 1 year. So we should ensure that the tract is dissected flush with the urethra and all the unhealthy tissue is excised and inverting watertight closure. And we should have some in-between interposing tissue. So, for example, this is a dartus flap taken from the dorsal skin, which can be brought ventrally, then interposed. And split dartus flap may be used if you have more than one fistula, one very proximally and another one distally. And this soft tissue interposition acts as a mechanical barrier to the leakage and prevents the chance of leakage, and the dead space is filled with that. So this is a tunica vaginalis flap. So here you see, this, especially in a proximal hypospadias, the scrotum is very close, the testis is very close. Even through the same incision, the proximal extension, we can bring the testis and the tunica vaginalis out. And we should ensure that the epidermis is not divided inadvertently when we try to mobilize the flap. If we try to feel with our fingers where the parietal tunica is moving over the visceral tunica, our incision will not overlay the epidermis. And then we can mobilize the flap, and that is brought to interpose and then cover the ventral surface of the urethral repair. So this will ensure that non-opposing suture lines are obtained. And there are a few other options like anti-urethral advancement, free buccal mucosal patch, and there is a technique called modified sessile culp. I'll mention that shortly in the next slide. And we can even put grafts like great saphenous vein. So in a sessile culp, where there is in a hypospadia cripple, you mobilize the urethral plate, tubularize it, bury it in the scrotum, and then at a later stage, you can get a scrotal skin to give a ventral skin cover, and that can make it tube. Lastly, about the urethral diverticula, in those who have a very large diverticula, they can form stones within that. Often it's due to ballooning during voiding. This can result in dribbling of urine, formation of stones inside, and see these are stones that are collected in the diverticulum. This may require removal and then trimming down. And urethrogram shows that there is a ballooning in diverticulum. Here you see it's a very large diverticulum, and this can occur in the whole length of the tube. And this may require reduction of that, ensuring that an IFT is placed and adequate width is maintained, and then the blood supply is maintained. And just the skin part of the tubular skin, the epithelial part of it can be removed. And the rest of the subcutaneous tissue can be wrapped around for a second layer. And if there's a circumferential anastomosis, this has a greater chance of constriction. In short strictures, sometimes dilatations can be performed, but often it requires a redo. Persistent chordae, as I mentioned a couple of times earlier, can be a real bane for the repair. The meatus may be at the tip, but if there is persistent chordae, the repair can fail. So here you see the repair is good, reconstruction is good, the meatus is at the tip, but unfortunately, as a chordae is persistent, this adolescent required a complete division of the plate, placing buccal mucosa, and then retubularization. So we should ensure that artificial erection, Gitti's maneuver is done, and then we document that the cardiac correction is adequate, and urethral tube is mobilized satisfactorily. And then when we are corrected, repeat Gitti's test is done so that the reconstruction is complete. And some of them, when you use a para-meatal flap, they can be hair, which can be protruding through the meatus, or in scopy we'll see. Though it is ideal not to have it, sometimes, unfortunately, the skin of the proximal scrotum may get incorporated when we do the tube. And endoscopic laser depilation is described, though it is not available everywhere. Sometimes endoscopic placement of keratolytics may be done. Meatal regression and meatal stenosis, you decide based on how extensive that is. Some of them may just settle with just a division of the meatus if the proximal tube is intact. And if there is VXO changes, you can have a recurrent problem with that. Some of them may require calibration and reoperative granuloplasty. There is suture tracts in the skin that may require removal and then grafting. And occasionally they may present later with sexual problems, especially if there is a proximal hypospadias, the incidence is higher, and they need to be addressed with appropriate counseling. So to conclude, in redo hypospadias, you look at the urethral plate. If it is wide, you may do a tip. If it is narrow, you do a Snodgrass with the buccal mucosa. If it is absent or scarred, if there is skin or not, you decide on staged or single one. So in a tip, you use the graft and then buccal mucosa, and then from a lip or from the tongue, you place it. This is the first stage. Then a second stage, you tubularize it. And then this redo. If there is a scar inside, you may have to place a graft inside that and then tubularize it. So to conclude, choice should be based on the extent of deformity and the quality of tissue. Most distal repairs are corrected by single stage techniques. For proximal hypospadias, often stage repairs are required. The failed ones required a tailor-made option based on how the chordae is, how the tissue is, how the fistulae are, and where the meatus is, and is there any MBXO changes or not. So those are the references. Thank you.
Okay, great, Chandra. I know it's a very, very vast topic. I don't know how you have covered so nicely in this limited time and almost covering everything from the distal hypospadias to midshaft to penoscrotal hypertrophy stage and the single stage repair. So I'll just go to the chat section. I'll few questions from the residents. One question from resident, I think the name is not, it's USI 04. He has asked, is there any relation between the fistula rates if the caudal block is or penile block is given? Anything related to?
Yes, actually, some, there is some mention, but there is no scientific basis for that. And also, we have not consistently observed that. On the other hand, the post-op recovery is more pleasant if they have been given a caudal block. So it is better to give adequate analgesia so that the post-op recovery is pleasant.
Question from Arif. What is the best way of securing hemostasis when you are doing hypospadia?
Yeah, that's a very important question. So as I mentioned in the dissection, having an adequate traction, counter traction is important. So if the glans traction is retained on a drape, your assistant can give counter traction on the flap. So you'll be entering the right plane. So that will give you somebody's mic is on.
Can somebody, there's a background noise, please unmute yourself, please. There's a background noise from one phone, please. Thank you very much.
Yeah. Thank you. So that is first step. Next is to ensure that we have a bipolar, especially in those who have a lot of dysplasia, dysplasia of the spongiosum. You do encounter a little more bleeding, but using a bipolar diathermy will ensure that the hemostasis is controlled. And you can use a tourniquet when you're doing a glandsplasty when you're incising on the glands. And then once you have divided, again getting hemostasis with the bipolar diathermy and then tubularizing will also minimize the blood loss during the procedure.
How much is the tourniquet time you keep? You keep it for some time, or you keep on removing it and putting back again during your dissection and all?
Yeah, I do most of the dissection without a tourniquet. Only for dividing on the glans plate, I use a tourniquet. So that is maybe for 10 minutes or so. The rest of the dissection we can do without a tourniquet.
Okay. There's a question from Amit. How do you check that your cardiac correction is complete? I think you have covered it during your talk, but again, you can clear this doubt of Amit.
Yes, Amit. Yeah, so divide the ventral plate, we have to gauge how severe it is. So in those in whom you're not planning to divide on the ventral plate, we can ensure with a Gitti's test. But if you're going to divide, first you can apply a dorsal, what is that, ABLS and check how it is. And then after you have, with that, you can assess the severity. And the extent to which you make the ventral division will be based on what you have assessed before the division. Because after that, it can be challenging. And then you put a graft to close it. Sometimes after you put a graft, you can do the Gitti's again. But then often it leaks when you have done that. But that situation is quite rare.
Another question from Venkat. I think he has asked about anterior urethral advancement in management of coronal subcoronal glandular hypospadias.
Yeah, thank you. So that is mostly based on the parent's preference and whether you wish to really intervene. And some parents, when they know that it's not going to affect sexually, you may not be advancing at all. But if they prefer, you can do. And there are several techniques for that. For want of time, I haven't elaborated all those techniques.
And Dr. Chandra, one question. You have covered magpie. Do you do this procedure now, or it is just like a standard snot gas? Or
I do once in a while, sir. Especially when the ventrally, when we assess by the edges of the defective meatus, when we find that the glands, the glands is nicely pouting. If we make a nice collar and then dissect it out, we can bring it together and have a nice cosmetic repair. And then I remove the splints quite early in those in 5 days and then send them. Some of them do even without a splint, but I leave it for 5 days.
Chandra, I have a suggestion.
Yes, sir.
In the distal hypospadias, especially, if you dissect it properly, you find that you have a divergent spongiosa, which you can dissect it off from the corpora. And that comes out very well for a tissue, which can be a second layer. You do a spongioplasty, the results are excellent with that. That's
correct. That's right, sir.
Yeah, so this is what Dr. Keshav has told. This is a question again from Venkat. This spongioplasty, is it enough as a second layer? Or you need to cover this again with some other tissue layer?
Yeah, that's a good question. It depends upon the extent of dysplasia of the ventral tissue. If with the entering on the right plane, just close to the cavernous body, we are able to get a good spongiosum, single layer of spongioplasty is good enough. But in those who are proximal, those are severe, we may not find that kind of a good tissue at all. In which case, it's better to go for darters.
Yeah, I think you made a very nice point, because basically the pathology is the deficiency of the skin, darters, and the tissue in the ventrum. So sometimes you find it in abundance, sometimes you find it it's still poor in quality. But the slide which you have put where you have shown Dr. Amilal Bhatt's slide, a thick spongiosum, and that is also an art. And you made a point that you have to go proximally to find the spongiosum pillar on both the sides. And quite often we see Dr. Amilal Bhatt talking about double breasting. He gets it so nicely that he puts one layer and bring the other layer on over the first layer. Another question is that is again name not is the ID is QuizJK. The question is it's not a question, it's a request. He wants to see the video of a transverse preputial flap. Asoka 1 technique. I think probably he can be asked to contact you, and probably you can just
So
get in touch.
yeah, I'll just send type my email address. You please let me know. I'll send a video. I don't have one offhand, but I'll certainly make one and send.
Yeah.
I'll just type my email address.
Yeah, Chandra, thank you very much. That was all from the chat and chat box. And I think we have seen a record attendance of more than 115 residents. And I can recognize the presence of many faculty also, including Uttam Mehte, and our friends from neighboring countries. Pawan Charis is there as a honorary secretary of NOS. And now, before we go to the concluding remarks from honorary secretary and the chair,
If Pawan is there, you can ask him to speak for a while if he's there.
Who's it? Yeah.
Pawan.
Dr. Pawan, yeah, please.
Thank you, Arun sir. It's my great privilege to be part of this very informative session for our resident. I'm very thankful to the executive of USI, President Mallikarjun sir, and General Secretary, Honorary Secretary Kesab Murthy sir. Indian School of Urology is doing lots of training programs, and they are having very didactic lectures. They are very informative to all our residents. And I'm very thankful that now USI is taking leadership in our region, in the SAARC region, and they have been including the neighboring countries in the SAARC regions and considering our resident as their own. So I'm very thankful to the USI for giving this opportunity. And I'm hopeful that our resident in this region, within the SAARC countries, they regularly participate in these programs and many other training programs organized by Indian School of Urology. I'm very thankful, sir. Arun sir, thank you very much.
Thank you, Pawan. I think, is there any question from residents? They can unmute themselves and ask the question. If you have none, I think it's a time to sign up. Before we sign up, it's time to propose a vote of thanks and concluding remarks from Honorary Secretary USI, Dr. Keshamurthy, and Chair ISU USI, Dr. Rajiv Sood. Over to you, Dr. Keshav first, and then Dr. Rajiv Sood later.
Yeah, thank you, Dr. Chandra Singh, for a wonderful lecture on hypospadias. It was enlightening. You have touched most of the, it's a vast subject, but you did very well to cover most of the questions which the residents are generally asked for in the exams also. So they have a principle on which the surgery is done. You have covered it very well. I'm sure the residents will find it useful. And thank you, Chandra Singh, on behalf of ISU USI for this wonderful lecture.
Thank you, sir.
Thank you, sir. Over to Dr. Rajiv.
Thank you, Dr. Arun. This was wonderful beginning this year, and Dr. Chandra Singh lecture was wonderful. We are getting response, very good response in the very first event of this year of USI, and I am sure that residents are enriched in the competency-based education system, which for the uniform education, we are uniform education, uniform curriculum, uniform training, which is the mission of USI and Indian School of Urology. Now, this is the first two levels that know knowledge and know why it is done. So these two levels of competency we have discussed today, and we are now going to Euromed programs also, which demonstrate us the show part and show how. And then only we start our performance on mimkins, performance on cadavers, performance on in the wet lab, and performance in the actual hands-on workshops. So this is the system, this is the curriculum, this is the training programs which are integrated in the schedule of this year, and we will be sharing the schedule of the entire year very soon. And we are enriched. We are thankful to Dr. Chandra Singh. We are thankful to Urological Society of India, President Mallikarjun, our Honorary Secretary, Dr. Keshav Murthy, and my co-chair, Dr. Arun Chawla. On behalf of USI and Indian School of Urology, I thank one and all, and especially all the enthusiastic residents who have participated in today's program. This will be available in USI archives, and this is the 31st lecture which we are putting in the archives, and our list of last year's 30 lectures is already archived. We will be sharing with you at any time, and all are welcome to our future programs of Indian School of Urology. Thank you.
Thank you, sir. Thank you very much for the attention of residents.
Thank you, Dr. Arun. And I think
no, for the attention of residents is very important.
I forgot to thank our team, Navneet and all the back team of USI office. Yes, Dr. Arun.
No, for the attention of residents is very important that you regularly attend these classes. Actually, if you remember in our virtual conference, we had a small event of the award ceremony of Indian School of Urology, USI. And we have residents who had a good attendance and were very active in these programs. They got an appreciation certificates from the ISU USI. So I request and I urge all the residents to join in good numbers to just see how quality talk is today. If you see this talk, even if you have retained 50% is fine, but when it's uploaded in the USA archives, please go in again, refresh yourself with the talk, and if you see a case of hypospadias, assist and go back again. There is a lot of quality content in this presentation. With this, I again thank Dr. Chandra Singh, and again I thank Dr. Rajiv Sood, Dr. Keshav, Dr. Malik, who was there in the beginning, and all the faculty and the residents. Once again, good night.
Thank you.
Good night.
Bye.
Thank you and good night.
Good night.